Thank you for giving this opportunity to talk about this trial. So the paper is the efficiency and safety of darolutamide in combination with ADT and docetaxel by disease volume and disease risk in phase 3 RSN study. This was a meeting abstract presented in 2023 ASCO. The key objective here was to determine the efficiency and safety outcomes for RSNs in patients with metastatic hormone-sensitive prostate cancer by disease volume and disease risk, to determine if a specific subgroup of the patient could achieve greater benefit from combination of ADT, docetaxel compared to ADT and docetaxel only. So it was a sponsored trial by Bayer and Orion Pharma, and the paper I am trying to discuss here is a post-hoc analysis of the RSN study. So just revising the RSN study design. So what it was a global randomized double-blind placebo-controlled phase 3 randomized control trial where patient metastatic HPC were enrolled who were candidates for ADT and docetaxel, and with performance status 0 and 1, 1306 patients were randomized. Stratification was done on extent of disease, whether M1A, M1B, M1C, and depending upon alkaline phosphatase level. Here randomization was 1:1. Here ADT docetaxel was compared with ADT docetaxel with darolutamide. The primary endpoint here was OS. Secondary endpoint included time to CRPC, time to pain progression, symptomatic skeletal event-free survival, time to first SSE, time to initiation of subsequent systemic antineoplastic therapy, time to worsening of disease-related physical symptoms, time to initiation of opioid use for more than or equal to 7 days, consecutive days, and safety. So what happened when RSN was designed is the data from Stampede and Latitude was not there, and that's why they had to do this analysis. And RSN study concluded that Daro plus ADT and docetaxel significantly reduced the risk of death by 32.5% versus placebo plus ADT plus docetaxel in this metastatic hormone-sensitive patient. And the treatment emergent adverse event in both the groups were same. So in this trial, pre-specified subgroup analysis was done, and whether the disease was de novo or on the recurrent setting, the OS benefit was maintained. In here, what they try to do is depending upon the high risk or high volume or low risk or low volume, they did a post-hoc analysis to see whether the OS difference is maintained in this 4 group or not. The OS subgroup analysis was done by unstratified Cox regression model. And this is the definition they used for high volume disease: visceral mets or 4 or more bony mets with at least one of them beyond vertebral column or pelvis. For high risk disease, more than 2 factors or 2 factors, Gleason's 8 or more, 3 or more bone mets, and visceral mets. So coming to the characteristic baseline, in this we can see that whether disease is high volume or low volume, the de novo patients are more, 87% and 81 to 82%, either low volume or high volume as compared to recurrent. And similarly, in high risk or low risk, the de novo patients are more, 92% in both high risk of each of the stratification, and low risk it is 71.4 and 75.5%. So of 1305 patient in full analysis set, 77 had high volume disease and 70% had high risk disease, 23% had low volume and 30% had low risk disease. So in high volume metastatic HSPC or in low volume metastatic HSPC, darolutamide, ADT plus docetaxel prolong OS regardless of the volume status, and the HR for there was 0.69 and 0.68 respectively. Even if the disease was stratified according to the risk stratification, the OS difference was maintained in high risk as well as low risk group. Coming to the TREs, so coming to the secondary endpoints, time to pain progression, time to first symptomatic skeletal event, or time to initiation of subsequent systemic antineoplastic therapy, we can see across high volume, high risk, low volume and low risk stratification that the darolutamide arm did better as compared to the placebo arm. Coming to the adverse event, there was no much difference in whether it was a high volume disease or low volume disease, and the difference between the darolutamide and the placebo arm also was not very significant. So what they concluded is that darolutamide improved clinically relevant secondary endpoint versus placebo either in high volume or low volume risk subgroups, with HR generally in the range of those observed in overall population. The incidence of treatment emergent adverse event were consistent with the overall RSN population across subgroup, even if we analyze by higher low volume or higher low risk. And the OS difference is maintained in all the 4 subset. Thank you.